Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your co-host, Brian Waterman, a sports and shoulder elbow surgeon at Wake Forest University in association with Atrium Health. I'm fortunate to have Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, as my co-host. How are you doing today, Peter?
Oh, everything's great. Glad to be here with you.
Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons, the University of Utah, Wake Forest University, or any of the institutions of our guests. Today we have the unique and distinct privilege to welcome some current giants in the field of physical therapy. All have doctorate degrees in the field and wear a number of different hats. Truly triple threats: involvement in research, clinical care, and leadership through education. I want to go through our guests. First, we'd like to welcome Ellen Shanley, physical therapist and clinical research scientist specializing in upper extremity injuries. She's a past president of the American Society of Shoulder and Elbow Therapists, or ASET. Ellen, welcome to the podcast.
Thanks for having us. Excited to be here.
Next, we have somebody that we don't have to deviate too far from the Greenville area. Where Ellen is, we often find Chuck Thigpen, who leads clinical services and quality improvement as the Senior VP for Clinical Excellence at ATI Physical Therapist. Chuck, welcome to the podcast.
Thanks for having us. Glad to be here tonight.
And last but certainly not least, we have the honor to host fellow podcaster, Mike Reinold. He's the president of Champion Physical Therapy and Performance, senior medical advisor to the Chicago White Sox, go Sox, and fellow leader in the field in physical therapy, strength and conditioning, and sports performance. Welcome, Mike.
Thanks so much for having me. It's going to be a fun podcast.
All right, so we've got the introduction set up. You know, I've had the privilege to work with all of you in a previous capacity, and I know your unique skills and abilities. But despite a little bit of internet sleuthing, we may not have a full grasp of what you all do on a given work week. So for those listeners who maybe don't know you as well, I'd like to take a little bit of a deeper dive into, what you do, the other hats you wear, and kind of your standard work week. Mike, do you mind if we start with you?
Oh, that'd be great. Well, it's daunting to get the first question started off. I'll be happy to. As you mentioned in the introduction, I have a sports PT clinic and a sports performance gym up in Boston called Champion, and we do a bunch of different athletes, but we have a high focus on baseball players. So do a lot of rehab on injuries in baseball players, but also working with athletes that are trying to take their performance to the next level. So get to do that, and I'm pretty fortunate to get to work with a lot of Major League Baseballers still, and work with the Chicago White Sox, which is always fun to help at that level. So really, again, just fortunate to be here and to be able to share some of the experiences that we've had.
Yeah, thanks for that. Ellen, do you want to tell us a little bit about your current capacity down in Greenville?
Sure. I have the great pleasure of working with Chuck and some of the other folks who run our residency. So we have a PT, sports, and orthopedic residency, and I get to work in that capacity, as well as our baseball fellowship. I get to do some great research and collaboration with the Steadman Hawkins Clinic of the Carolinas. So get to see a lot of baseball players and other athletes. And then at ATI, I also help with Sports Medicine Network, where we have over 200 athletic trainers and athletic training sites in high schools around the country.
Great. Chuck, anything else to add? You've got a laundry list of accomplishments.
No, I think I'm fortunate to get to help lead clinical services across ATI and our clinics. But I think most fun is being able to hang out with Ellen and fix problem shoulders, quote unquote. So we've been doing it a long time, and fortunate to get to work closely with her.
That's great. You all definitely are leaders in the field, as I've alluded, and we want to lead right into our clinical topics. As we were kind of crafting a little bit of the premise of this podcast, we really wanted to go after some of the big kind of myths or giants in terms of clinical topics. And so we want to get right after it. Let's talk about GERD, right? Glenohumeral internal rotation deficit. And one of the biggest proposed risk factors that we see in upper extremity injury is GERD. And it seems like it's commonly a source of targeting with PT intervention. Chuck, I know you have some strong feelings on this. Is GERD as a concept, is it dead, or is it a modifiable risk factor that we can still optimize despite those adaptive changes that occur in the shoulder with continued throwing?
You're just teeing me up, Brian. I think when I think about GERD, we've been looking at it a long time, and I think it's one of those things that because we could measure it, we decided it was a problem and didn't look at it in the whole context. And I'm sure Mike will be ready to remind me that he's been telling me this for 20 years. But I think as we've looked at it, what we've learned is while internal rotation deficit in the context of total arc is modifiable, it's very common in throwers. It changes over time. Some of Mike's research, some of our research shows that it truly changes not only with age, but also with time in the season and degree of stress. And I think most surprising to us is, as we really dug in, is humeral torsion influences the degree of internal rotation deficit. So without that context, it's probably not a very good impairment to focus on alone. And I think what's the last thing I'll say is that over time, pitchers have changed. They're much bigger than they were 20 years ago when I really started leaning in this area and really trying to understand the throwing shoulder. And I think the weight training and the nature is really, I think, left us at internal rotation for sure alone, and then probably not very common is the most, the number one factor, if you will, to really address. So I think it led, a little bit joking, maybe not joking, is that GERD is dead. Mike might say it was never alive, but I don't think GERD was defined by Dr. Morgan and Burkhart and Kibler. I guess that arthroscopy paper was 99 when they originally defined it. I don't know as they originally described, is that really how we think of it today?
Yeah. Mike, what do you think? Does this influence your evaluation and management of these athletes with presenting GERD?
It's definitely something we always look at, but what we've learned over the years is that it's important to look at motion of the shoulder with the context of total rotational motion on both sides. So both internal and external rotation added up, compared bilaterally. And I think what you'll find oftentimes is that internal rotation, whether it be less than the other side or not, which obviously it often is, it's not usually the thing that I'm most focused on. And I can sincerely say, and this is not embellished in any way, that I haven't worked on restoring internal rotation in a baseball player in 15 years, maybe longer. It's just not something that we focus on. And if you look at the changes in bony adaptations that we've seen over the years, I think you could argue that if somebody has a limitation in internal rotation, that their injury risk may be more to do with their excessive amount of external rotation that they gain from the subsequent bony adaptations than it is the fact that they have limited internal rotation. So it's not really something we work on, we focus on. We don't do any treatments for it, and we tend to have great success by focusing on other areas. So really, just hasn't been a primary focus for us.
The only thing that I would add here is looking at some younger athletes. I think when you get somebody who's growing, it's important not specifically for internal rotation deficit, but all range of motion, to make sure that they're continuing to work on their extensibility as they're growing. Because I think throwing and growing at the same time tends to leave younger athletes a little bit tighter. So those, 14, 15, maybe even to the 16-year-old level need to really focus on their flexibility as well when they're going through those big growth spurts.
Certainly,
Yeah,
that's
I like
great
that.
information. Yeah, I love that. I mean, can I ask you maybe as a quick follow-up, Mike Reinold, about that? You've done some work to show just how quickly range of motion can change with weighted balls. Can I ask each of you, just before we move on to other pathologies, when we talk about range of motion, like what do you have parameters around when you when you make those measurements, try and compare patient to patient? Maybe you could start, Mike.
Absolutely. Yeah, absolutely. And I think it's important that you have that. And what we're finding, and I actually just talked to one of our physical therapists about potentially writing this up because we do enough physicals now at the beginning of a competitive season at different levels that you have to understand what to expect with total rotational motion. And I remember 25 years ago when I was getting started in this, it was almost as if everybody had 180 degrees on the dot on both sides just when you add them up, and it was so consistent, and the standard deviation was so straightforward that it was pretty obvious. Nowadays though, it's so much different, and if you look at our high school athletes, they have way more total rotational motion than college, who has more than pro, and you can see that evolution like Ellen kind of alluded to with her response there, is that it matters. But for us, I think the thing that worries me most, or the things that I see more in the current age of pitchers, is that people have too much of a rotational window. So meaning that their total rotational motion on their throwing side is larger than the other side. So for example, maybe it's 200 degrees versus 190 degrees on their non-dominant side. And we often find that attributed to a gain in layback or external rotation from all these forceful extreme throwing things that they're doing with extreme long toss and weighted balls, just things that actually have been shown to increase that layback. And to me, that is what's so disruptive and what is leading to so many of these injuries in not only just the shoulder, but the elbow as well. And that's something that we try to pay attention to during our exam quite a bit.
And maybe
Yeah,
I could
I
ask,
think oh,
please go
sorry.
ahead. Yeah.
I think it's really interesting, as Mike puts it. You see this excessive range of motion, but we also see other places that we never used to see lack of range of motion. Like you look at some of the recent workout on cervical range of motion and cervical rotation in pitchers, and we see that side to side there's differences there. There's differences in thoracic rotation. So I think a holistic view at flexibility and extensibility is really critical when you look at somebody not only at the beginning of the season, but watching them throughout the season, throughout their pitching effort and their recovery, and seeing if they can restore that range of motion.
So maybe with that baseline, that there's some understanding that maybe excessive range of motion is dangerous. Jimmy Andrews a long time ago told me that he thought internal impingement was an over-rotation phenomenon, that the players were getting too much rotation and that created the internal impingement. So Chuck, do you agree with that? And then when you talk about internal impingement, what do you look for? Like, what are your predictors of success? How do you get the players to succeed when they have that problem?
So I think a lot of times things come back around, and I think about Dr. Job's original hypothesis of micro instability is he kind of originally described kind of the initial trauma, and I think actually in some ways, to Mike's point, we're coming back to that point. One of the interesting things I think to keep in mind is the French's solution, right? Like everything's different in Europe, and what they showed is that they cut the humerus and derotated it, i.e., created humeral retroversion. They could resolve the internal impingement. So I think it's this interesting interplay between what Mike said, this over rotation or layback, without a balance of internal rotation on top of the torsion. And I think that's, in my mind, that's kind of how it's setting up. And so I think in these athletes that are getting, because I think Dr. Andrews is spot on, at least of what I feel like I'm able to change clinically, is those athletes that I can modify their mobility and help with their strength to be able to control the humeral head. They seem to be able to manage that internal impingement, no problem. The challenge is for those athletes that can, and I think that's probably, at least for me, when we, and I don't want to go too far down a rabbit hole, but when we start to think about this extension of the slap tear down the back, is I wonder if we're actually seeing instability start to develop in these athletes with too much motion, as opposed to just the internal impingement, if you will, that Dr. Andrews, Dr. Job were describing. That the early gentle striping, as I've heard Dr. Andrews called it, was pretty effective in addressing those throwers in some of the early cohorts. So I think for me, it's understanding when that excessive layback and the internal impingement symptoms are there. Can I change it with mobility? So by centering the humeral head, doing some overall posterior mobility work, can I resolve those symptoms? Or is it actually driven because of maybe maladaptation or over-adaptation to throwing?
Ellen, I'd love to hear your thoughts as well. I mean, do you agree? Is that the way you approach internal impingement? What differences might you have with your approach?
I think, I read with interest your article in 2023 looking at workload there. And I think, a lot of our patients who seem to come in with internal impingement symptoms have a lot of range of motion, but they don't have a lot of strength and other muscle performance kind of characteristics. So I look at, do we have to center them? Yes, but we also have to have good control throughout the range of motion that they have. And I think that's the one thing that's the focus that I like to emphasize with athletes as they're going through the season. They have to be able to restore not only their motion, but their strength, and they have to be fatigue resistant. So we have to give them some endurance to that, I believe.
Mike, do you agree? Is internal impingement, is it a strength issue? Is it a control issue? What's your approach to players when we see specifically that problem?
Yeah, I mean, I agree with like the concept of Dr. Andrews of the over rotation because again, we're seeing this in people that to me have too much external rotation more often than not. And ironically, I'm actually seeing internal impingement less and less. Maybe that's just because maybe I'm jaded just because I see so many elbows now. Maybe there are more, there's still the same amount of internal impingement. It's just that elbows have taken over. But we see people with this over rotation, and I can't tell you the last time I had somebody come into my clinic with shoulder pain or even elbow pain, and I bring them through an examination, and I don't find a huge checklist of suboptimal findings. To Ellen's point, to an extent. So, there's soft tissue limitations. They lose overhead elevation. They have too much external rotation. Their strength of their rotator cuff and their scaps are just terrible, right? And you wonder why these kids are hurting when they're throwing. So they have no capacity, yet they're working these tremendous workloads, doing all that they do in baseball. It's a game that they're not going to win. So for me, it's this over rotation on this checklist of suboptimal, and that was just upper extremity. To Ellen's point, the whole lower extremity, their core, their lower body. I mean, these kids are in such terrible shape because they're so focused on the specificity of baseball and not on actually improving their capacity. That I think that is why we see so many of these kids running into trouble.
Yeah, you've definitely alluded to a couple evolving management protocols and algorithms. I want to talk next about the refractory slap lesion. Nowhere is it more humbling, I can tell you, for a surgeon, and certainly from a rehab specialist, when you encounter these patients in clinic. Peter's shown some sobering results with biceps tenodesis in professional baseball athletes, particularly those pitchers. And we have a series that's out there that's comprised of about half baseball athletes, but not all of which were pitchers. And it showed some modest success. I'm curious to elicit your perspectives. From rehabilitation, what's been your experience with biceps tenodesis for those refractory slap lesions where non-operative care has just not been met with a great result? How about Ellen? Let's start with you.
You know, I hate biceps tenodesis as a focus of my rehab. I feel like that's one of the hardest problems to rehab in a thrower, and they end up, I think, struggling through the attempt to get their range of motion back, and it almost seems like we take their adaptation away. It's a long process. It's, I think, a difficult balance between getting them their extensibility and getting them their ability to function at a good triplanar motion. They get pain throughout their range of motion. And so I think we haven't seen as much success as we thought we would with biceps tenodesis in SLAP lesions. It almost seems like we do better with somebody who does get a SLAP repair, but only if they had instability, which underlied the original problem of the labral tear as well. And I don't know, Mike, maybe you have a better experience than I do with that, but I don't see a lot of success in there.
Yeah, I share your sentiment that I'm not excited when I see a biceps tenodesis patient on my schedule. I don't want to say the word salvage procedure, right? Like, I don't know if that's a fair statement here, but to me, it seems like this is an athlete that just we can't figure out how to really get them over the hump. And maybe they're just too beat up on the inside in general that maybe they're not going to get back in general. So I can't say I've seen a lot of success stories. I do feel like the wave of injuries in baseball in general is getting younger and younger. So meaning these kids are getting hurt like larger injuries at an earlier age. So I think a biceps tenodesis is maybe a little bit more of an older athlete that we've seen, and I feel like those players just their level of just how they're beat up is just something that at that point I'm not sure that's going to be what the solution to their problem is.
Yeah, Chuck, what do you think? What's the role of the biceps tendon in that athlete, that competitive thrower? Is it humeral head depression? Is it assisting with deceleration? Why do you think that it occupies such a prominent role? And Ellen, I'm going to challenge you because Rich Hawkins is probably squirming in his seat right now, thinking that you're saying bad things about the biceps tenodesis.
Well, he's just going to let it fly. He's not going to tighten it down, is he, Chuck?
No, he's just gonna cut it and let it go. And I think you know where we live, Brian. So I think Hawk for sure, living in the land of bicep killers. I think what I would say is one, it has some external rotation depressor function. I realize that's not what it says on the anatomy test, but I think what I find is in these, I think about the pictures that Mike talked about with the excessive layback, it seems to have a role in compressing. If you listen to Dr. Kibler pontificate, he sort of has this interesting idea of biceps on full length and the difference in external rotation. I haven't completely gotten my mind around that, but I think it's the ability of the biceps to be a secondary stabilizer. If you go back to some of the early work and actually Doug Harriman and their shoulder biomechanics, the green little Bible in my head, they talk about just a little note that maybe biceps sits there. So that's how I think about it. And then when I think about the things Mike and Ellen, my experience is the same. It's about like your paper, Peter, maybe 1 out of 2. Right? Maybe a little better than flipping the coin, but not much. And I think it speaks to Mike's point. It's biceps typically pretty beat up, right? It's not a clean, pristine bicep. It's got synovitis all down in the groove, and other things that really seem to make it hard for that pec-lat complex at the distal end, depending exactly where it's tenodesis, to sort of relax and allow for that full layback. Because layback isn't just external rotation. It's actually the ability to pull the scap back and hyper abduct and get the elbow behind the body. and externally rotate. And I think when you get that biceps tenodesis, folks just really struggle to find that slot again, if you will, even if you can get past the pain and some of the early post-operative and return to throwing pieces that Mike and Ellen alluded to.
Yeah, I mean, we have that original paper. We actually published an updated paper that has a much better return to play that shows, kind of 70, 80, 90%, depending a little bit on whether you're looking at a pitcher or position player. The challenge, I hear you, Chuck, that there's this idea about the biceps being a depressor. I think the challenge we have with that is it really doesn't necessarily line up with more recent clinical data. I mean, probably the best piece of data I think we have in the biceps tenodesis for in vivo is the biplane study that I think Peter Millett and Matt Preventure did, that shows that there's really no proximal migration in vivo after a biceps tenodesis. But I think what you say, Mike Reinold, is true, that it's really challenging to analyze the results because so often it is used as a salvage procedure. And so there's a real selection bias. There's a collinearity problem. The players that are getting tenodeses are often at the end of the road. I think probably most surgeons would agree that biceps tenodesis for them is a pretty rare procedure for a thrower. It'd have to be just the right specific situation. And even then, they probably tell the thrower that just like any shoulder surgery, getting back to play after a biceps tenodesis is really challenging. I heard from a lot of you guys that rehabbing internal impingement, you got to work down the chain. You got to work on the core. You got to work on the lower extremity. I think a lot of surgeons increasingly find this, that core strengthening is a key part of rehab of throwers. I want to just get a couple of pearls about if you see a player in clinic, you have 5 minutes with that player. What are your favorite ways to test core strength? And then if you have 2 minutes, what are your favorite exercise for core strength that are good for throwers specifically? Because throwers' core strength is different from, other athletes. They really need rotational strength, through the thorax. So maybe, Mike, could you start us off? Get us onto core strengthening. What are the best tests? What are the best exercises?
Yeah, that's a great question, and definitely something that I think we need to draw more attention to. So I'm glad we're talking about it in the podcast today. I think sometimes we're so focused on the area of pathology that sometimes we miss some of these things that are down the chain, like you mentioned. So for us with core, we think of core in two ways, right? There's core strength, but there's also core mobility and the ability to transfer that strength. And I do think you have to kind of look at it all together. So our athletes go through like a full movement assessment of their entire body. So we want to see how well they do things like squats and lunge and hinge and those types of things. And I think that tells you a lot about core control during those. We have tests like, plank tests where we're looking for some core endurance. But for us and our rotational athletes, we like to use more rotational based drills for them. So we'll look at rotational power with like med ball throws and those types of things and put it all together. So if you're looking at core strength, some planks and those basic types of exercises, I think you have to combine it with the ability to turn that into rotational power. And you can measure that with, radar, or, there's machines now like Proteus that you can use that can help measure some of those things. There's ways you can do that. And then how that all goes together with how well they move. And to me, I think it's those three pillars for the core that we have to look at and put them all together.
What about you, Ellen? Anything you'd add to that?
Yeah, the way I want to take this is more looking at the youth athlete, because I think Mike did a great job of explaining what we were going to do with a college or professional player. But with a youth player, a lot of times they're playing a position where they can't even balance and control their positions in single leg or in a lunge type position. So you have a youth athlete who's pitching often and can't do a walking lunge type of activity. So we like to start in, a double leg squat, a single leg squat, and then doing a lunge, and working on walking lunge with some perturbation is really helpful to teach them how to activate their lower extremity and their connection to the core. and then work on rotation from those positions, I think is important in the youth to adolescent athlete. Once you get to the adolescent athlete, Mike again kind of focused a little bit on the rotational extensibility and making sure they can turn both ways, because I think they do get in these baseball patterns where they don't rotate the opposite way and have full rotation right and left. So those are some things that we would do with some of our youth athletes.
And then Chuck, what do you think? And then Ellen mentioned perturbations. Just for the surgeons listening at home who may not be as familiar with that term, tell us how you would perturbate someone as they're doing lunges.
No, it's great. I'm happy to help. I'm not nearly as smart as Mike or Ellen, so I think of it really in three actions, and then perturbation's super complicated. You push them, right? A little push, a little shake to kind of knock them off their base. And I think from an assessment, really something a pitching coach that Ellen and I worked with taught us was to have a pitcher stand on their stance leg on like they're standing on the rubber, and they should be able to do a single leg squat and bend down and touch their shoe with their glove hand. So they should be able to take the back of their glove and put it on the top of their laces. If they can't do that standing on the rubber, there's no way they can be and really have a stable base to start with. And then out on their lead leg, wherever their spot is on the mound, so typically a slight decline, same thing now on their lead leg. They're out on that front foot, and they should be able to take their throwing hand and go from their, kind of their slot and reach down and touch the toe on that side. If they can't do that and come back up to where to their slot, then they're not able to pitch. And that seems to really resonate with kids because they understand those basic pitching maneuvers that coaches are asking them to do. And then at each of those positions, you can do it in a clinic, take a stool, have them stand there, and you just give them a little push on their hip. It usually can show that they can't withstand the force required to pitch. And then the one other core thing that I really like is just a simple side plank, and showing the difference between the stance leg and the lead leg is often really telling. Their ability to just get in a simple side plank and hold it up is super amazing how weak they typically tend to be on both sides, but more pronounced on their lead leg.
Thanks, Chuck. I'm feverishly taking down notes so I can get all this stuff ready for clinic on Thursday. Those are great pearls of wisdom, truly are. Next thing I wanted to talk about is a little bit about in-office biologics, specifically PRP for those partial UCL injuries. I would say that the data is decidedly mixed, and at the same point in time, we still remain optimistic for a lot of these young developing athletes where we're trying to avoid UCL surgery. I'm curious, from the time that you see them after injection to the time they return to throw, walk me through what that looks like. I want to talk specifically about timelines, how you engage, what are the things that you'll permit, how do you manage some of these flares that occasionally happen after PRP? Ellen, could we start with you?
Sure. I think, for us, it really depends on the age of the athlete, the position that they play, and some of the contextual factors. But as with most of our UCL rehab in general, we start with the lower extremity and the core, just because in our timeline, we know that in a lot of our young athletes, these are some of the areas that they've been deficient in, which probably put them in the situation where they're in right now with this type of injury. So for the first, say, 4 weeks, we'll spend most of our time working on their core and their strength while we look at, their comfort in terms of their overall ability to get their range of motion back bilaterally, and then slowly work them into, over a 2-week period, some isometrics and then some active and light resistive exercise. If they do have a flare, we focus a little bit more on, their overall lower extremity and core again, but keep them moving through some of the lower exercise, like a 48-hour back off of some of the activities that they're doing, and then a slow, gradual progression again. And all along, we're doing lots of core trunk activity to get their mobility back and make sure that they've got good ability to rotate in both directions, work on any kind of range of motion deficits that they may have, or things that we think are significant to their return to throwing program. But typically, it will take a couple months to get them all the way through the process where they're not having these flares back and forth again. It's a little different if that player is not going to pitch again. Maybe shortens the timeline by like 20%, I would say, if they're an infielder or an outfielder.
Mike, I've often offered the rule of thumb to my patients. If there's a 6-week time frame where there's active rest and avoidance of throwing, then it's probably twice that for the back end of that with the return to throw progression. I'm curious to get your comments on what Ellen's just shared, and then also specific timelines that you think we should provide to our either young developing patients or our professional athletes.
Yeah, that's great. I mean, it's really hard to add to what Ellen just went through there. I think that was an excellent overview of a scenario. For throwing to the question that you kind of had there, I think a lot of times we don't often take the time of the year into consideration, and we say things like, okay, let's go through a 6-week throwing program or a 12-week throwing program. But sometimes that end of that 12 weeks is November, and you might have a high school kid in the New England area that doesn't really need to throw in November. So, you take a step back sometimes and you say, are there areas that this athlete is so deficient in that maybe that kind of got them in this mess to begin with, like their poor lower body strength, their poor core control, their, the fact they've never done a rotator cuff exercise in their life, right? Would we be better off slowing down this return to throwing program and actually focusing on their body more? But, the fastest we go if we're in a rush, I'd say is, pretty equivalent to whatever time down you are is how long it's going to take to come back. So, probably to your point. So if it takes us 6 weeks down from an injury, it's going to take us at least 6 weeks to kind of get back to where we were. But, again, I urge everybody here to not just work in finite calendars and dates, and actually think about like the next 12 months for this athlete's career and what they need to get back to. And maybe there's other areas that we can kind of periodize within that calendar a little bit more individually for each athlete.
Yeah, that's great comments. Oftentimes what comes up, to your point, is the opportunity cost of undertaking PRP. That's a sizable chunk of time that you're investing in what you anticipate as a recovery. And when you encounter these patients that don't get success, it's often frustrating to them. So I'm curious, Chuck, what are your rates of success in being able to get athletes back to pre-injury level of activity with PRP, just anecdotally speaking?
I think it's really in two buckets, and Ellen and Mike both hit on it. I think level of athlete's a huge delineator. So if we take out that this is the gradual onset athlete that's having elbow pain, and I'll say put a cap, not your 25 and older, because I think that older elbow is just a different animal. But in the relatively younger thrower, I think it really helps in two ways, and pretty good success. Mainly around because it hurts and it forces them to shut down, especially as you get into those teenage throwers, and buys some time. And I think to Mike and Ellen's point, both is extending the time to throw. It makes them realize that, hey, it's either this or it's 18 months back after UCL reconstruction. If this is the chance to avoid surgery, I think allows them to focus on the other areas and really take their time through return. And those kids seem to do really well. Where it struggles, though, is in the ones that are looking for the quick fix. They're looking to be back in 6 to 8 weeks on the mound. I think that's a tall order to ask, and haven't been honestly very successful in that setting.
Yeah, I think that's I totally agree with you, Chuck, that the player that's got a timeline is always the one, like a short timeline is always the most challenging. We've gone through a little bit non-operative treatment UCL injuries. I want to talk about operative treatment. This has gotten so complex now. We have repair, we have reconstruction, and lines are getting blurred. I mean, there's people doing hybrids that are kind of on reconstruction surgeries, more on repair kind of timelines. Even the repair timelines, people are increasingly saying they're pushing back. I wanted to hear from you guys a little bit about this. As you approach the player with a UCL repair, reconstruction, hybrid, what are you actually seeing in terms of return to play, in terms of timeline, and what have you found those to be realistic? How are they changing over time? Maybe we could start with you, Chuck. What are you seeing out there right now?
Yeah, I think we do not see them as much as I think probably Mike does in his population, but I'll let him speak. I think really what we see is we are willing to open up and start a little faster, which gets you back on the mound faster. But it actually comes back to this question we were just talking about with PRP: is that even what I want? And so I think from the get go, given the timing of the season, really establishing that window of return to play and return to performance for the athlete is really the most important part. And then to Mike's point, work backwards from the throwing program and what are the physical things that have to happen, as opposed to, I think a lot of times we work from the surgery forward and see how fast we can go. And I think really, given the significant time and investment it is for the athlete, family, and everyone, is really trying to call a big time out there. So I think, um, you know, clearly the internal brace can accelerate things, gives us a little more comfort in going faster. But I think really understanding what the end goal is what I really try to emphasize. We've had really good success, like we've seen in the literature and stuff. But I think it's really in the context of who is the athlete and when really should they be back. Look, if it's a professional athlete and they've got a different incentive level, I think that's one context. I think I become concerned when I see us taking our 14, 15-year-old UCLs and rushing them back to pitch. That seems counterintuitive to everything we would say on the preventative or reducing injury side.
Yeah, I would
Ellen,
agree, Chuck. Oh, sorry.
Please, I
thought Chuck pitched it to
go
me.
ahead. Mike, I really want to hear what you have to say here. So please go ahead.
Yeah, I mean, it's interesting. The results that we're getting out of the internal brace have been excellent. We've been thrilled by it. We haven't really seen issues with it, which I think is exciting because it gives people an option, right? Especially if they have restrictions in their time, or maybe their tear is not as significant and they don't need as an aggressive as an approach. But I'll start with the traditional Tommy John, and we treat our hybrids the same as the traditionals essentially. I've seen a lot of different changes over the last 25 years of my career. We used to be more aggressive. We slowed down. I see some people slowing it down more. I know some people say we shouldn't get back until a year and a half. And when you look at their recommendations, it's no throwing for 6 months, which by the way is an eternity for an athlete, or 7 or 8 months, whatever. It's an eternity for an athlete. But then the throwing program seems rushed from there. So it's a wait, and then go. And I don't think that's the best approach either. So we just published our interval throwing program that's been based off workload data. So torque measurements and how that changes throughout an interval throwing program. And to us, we wanted to make sure that we were very strict with our chronic workload buildup, but also our acute chronic workload ratios to make sure that we are giving enough stress, but not too much. And both sides of the equation are just as bad. You don't want to underload or overload. And our Tommy Johns are ready to get back to a rehab assignment or whatever it may be for that person at about the 12 to 13 month mark. And we just have not seen the need to slow that down anymore. Now, again, that's not a 16-year-old kid. Don't get me wrong. That's different. But we just haven't seen that need. On the flip, and here's the interesting part, I can't tell you how many times that I think an internal brace protocol or the suggestions on how fast to go seemed too fast. And just think, for example, if we start throwing 12 weeks after an internal brace procedure with a 16-year-old kid, that's a month of almost like, damage control, like, trauma control from the surgery, maybe a month of starting some exercises. And then we're getting close to get ready to the throwing program. Those kids aren't ready. There's a reason why they probably needed Tommy John surgery to begin with. They're not ready. And a lot of times we feel rushed, and I don't feel like they fulfill my criteria to begin a throwing program other than time. So we often slow them down quite a bit. And, I had another great example in the last couple weeks. We had somebody that also had a stress fracture and had a screw posterior with an internal brace. And I didn't think the screw was ready. He was getting posterior pain when, we're trying to get ready to start a throwing progression. So we had to slow it down. So, I think it's great that we have the ability to potentially go faster in the right person, but that doesn't mean we have to. And I feel like that's a recurring message that we've all kind of stated a few times here tonight, which I think is pretty neat. I feel like that's something that people need to probably be aware of here. Again, it's looking at the calendar year from a holistic approach from the beginning and trying to map it out for what's best for each person.
The only thing I'll add, because who could add much more than that, is that the athletes themselves have been interesting as they come back and they talk to you about their rehab and then their initial experience back at competition and stuff. And most of them have told me that they feel like they still don't have the return to performance back for 18 months to 2 years, even though they started throwing and they started some competition much earlier. They still don't feel like they're recovered until like 18 months. And they feel like they're still struggling with their control. They're still struggling with, getting the feel, their touch, and they're still concerned and almost a little bit more afraid to let things fly until they get into, about 20 months. So it's interesting that they have that opinion, sort of whether they have an internal brace or a traditional Tommy John.
Yeah, I love a lot of the points that you've brought up. For many of our athletes, we're equal parts clinician, mental health coach, cheerleader. And Chris Camp has alluded to this in one of his publications. At least 1 in 5 throwers will experience a setback in their throwing progression. And, I often struggle with this. How do you manage expectations with these interval throwing programs after UCL injury? And how do you navigate some of the subjectivity of pain and symptomatic reports that athletes often give? The language is a little obscure. Sometimes it's hard to correlate, and especially if somebody's a little bit on the anxious side of the house, right? I often struggle with trying to interpret what's real and what's not. So, Mike, why don't we lead in with you? What are your thoughts on this?
Well, the first thing we do is we try to decide if their discomfort is just normal, and do they? You could almost put anybody on the table and just lay them supine and bring them back into full external rotation. And if they feel great, which they do, you pat them on the back and you say you're good to go. And that that's essentially a milking maneuver, right, for the arm. You say, look, you're stable in here. You're doing a lot of exercises. You're working out in the gym. You're starting to increase the workload. Your forearm's probably getting a little sore. That's what that really comes down to. But for me, it comes down to observing them, making sure that we're on top of that, because I do feel like I'm more of a psychologist than a therapist half the time as they're going through these progressions. But I do think that's why it's super important that with the interval throwing program that we just published in the International Journal of Sports Physical Therapy is that you follow these workload progressions, because it's very easy to spike or underload their workload progressions and their acute chronic workload ratios. And it happens all the time. We have to be careful with that. And I think that's what gets players back the safest and the most gradual. We also build some deload periods into it, which, by the way, our biomechanists hate, because if you take a week deload, then obviously your chronic workload flutters a little bit and your acute chronic workload ratio spikes for a little bit. But for us, it's worth it for us because we want to get them to deload. We want them to heal up a little bit. We want them to feel better. Sometimes we tell them to go home, right? If they're in spring training facilities right down in Arizona or Florida, like, go home, clear your mind a little bit because they need to get ready for this next half here. So, for us, I think it's about management of workloads and making sure we're following a program that uses acute chronic workload ratios. I think that's enormous. And to Ellen's point too, I think this goes with it. Like, we analyzed the pass interval throwing programs that we published, right? The ones that most people use, we published 25 years ago. And we actually showed that the chronic workload buildup that we had at the end of the interval throwing program was very similar to mid-season chronic workload buildup in an athlete. And you wonder why they come back and they're gassed that first year and they feel like they don't have anything. Or to Ellen's point, they're not comfortable, they don't have good command, they don't feel crisp. It's probably because we built up their chronic workload a little bit. So that's also something we adjusted with ours. And I do think with the newer approach, we're seeing people come back fresh and they're more successful that first season back. So to me, again, to answer your question, Dr. Waterman, I think it's about workload management and being really strict with that.
Those are great comments. One of the things that we struggle with is just the geographic disparities in some of our athletes, right? Some of the resources that are available are just not there in the Southeast. Chuck, I'll go to you next. How do you navigate maybe some of the misinformation or frustration or coordinating care with a local site that's distant to you in these interval throwing programs?
I think really, one, just to reiterate everything Ellen and Mike said, there's to your point about copious notes, that's how you get at it. But I think I find writing it down, and I think in particular for the reconstructed athlete, whether preoperatively or in that first postoperative check-in on the wound, is spending time with the surgeon and rehab team and documenting what it takes to get back. Here are the things you have to show me in order to begin your throwing program. Here's what you have to do to get back on the mound. And then I think to Mike's point around psychological readiness, look, it's a thing. It's interesting in the ACL literature, overconfidence is as bad as underconfidence. So I think we have to manage that. And I think what we're seeing is, growing up with Hawkeye, I love the saying, and I think it's interesting. We've actually got a paper that we're just finishing up that shows that the sane and young throwers actually measure something different than the fast, which is that really well-developed tool of AT Still that they, did all the right things to measure pitching, but actually the sane gave the better indication of when an athlete was ready to go back to throw. I don't know what it says, other than it says there's something else internally that athletes know. So I think as they go through documenting kind of the criteria and so there's alignment and everybody understands the therapy, the sports medicine group, the surgeon, the athlete, the family of what it's going to take. And then I think in progressing against those goals and sort of taking time, or at least time boxing it within what are the goals are, right? Do they have 10 months to the season starts and they want to start playing second base, or do they have 15 months to the next season? Those are two completely probably different rehab processes. And then the last thing I just add on, I love Mike's throwing program, is I really like the OmniRes, just a simple 0 to 10. How hard was your session today? I really like that as a part of a rehab, but also when they're throwing, because I think it gives you that piece now to have that ongoing conversation, which you can do remotely, right? Hey, how was your throwing today? Oh, I did X amount. How did you feel? Oh, it was an 8 out of 10 hard. Well, how sore are you the next day? And I think now you really get into the habit of being able to help guide an athlete, whether you're in your clinic and you got your hands on them every day, or if it's in a more remote setting or situation.
Yeah, Ellen, how can we as surgeons be better collaborators and guide the patients through this throwing progression? Any final landing words on this?
Yeah, I think it's important that they see us as a team, and that they know that they have almost like phone a friend kind of thing. So, we try to play that role for the Stedman Hawkins group in that we field a lot of distant athlete phone calls, but it's a collaborative thing. And so I think they feel really comfortable that we're involved with the surgeon who did their surgery and can get that communication. But I think it's really important. We do all of our post-operative visits for at least the first week if the person's going to a distant source with the physician. And so it shows that we have a group and that they feel like the communication then can be one that is successful, and that they'll always get an answer within 48 hours, because a lot of times an athlete will call in and there's nobody there to field their questions right away. And so we can get information back to them. But I think, being as transparent as possible and giving them as much information about what to look for, and what to be concerned about, and try to give them some hallmarks of things that they're trying to attain by the next time you talk is the best thing that we've found in terms of helping them stay on track.
Those are great landing words. I really am excited to have you three as guests. We obviously could talk about these things ad nauseum, but I want to be respectful of your time. I want to personally thank all three of you for joining us and really educating our listeners on a lot of these pretty heady topics. We really have covered a lot of ground. Thank you so much for being involved.
Thanks for having us.
This is amazing. I mean, all three of you gave just stellar words of advice, and it's so useful to us as surgeons to hear your side of things, because I think so often we don't have what you mentioned you have, Ellen, which is the close collaboration, which is so critical for success, especially with throwers. So thank you all for all the time that you gave to us this evening. I'm sure our listeners will love this. For all of our Shoulder Never listeners out there, don't forget to subscribe. And for Brian Waterman, I'm Peter Chalmers, and we'll see you next time.